I think it's been one of the real revolutions in prostate cancer is the use of MRI. And we've used MRI for many years. Actually, there were radiologists 20 years ago when I was here at UC San Francisco who were heavily engaged in MRI and its characteristics for prostate cancer. But I would say in the past few years, it really has emerged as a powerful tool. And I think probably the more powerful magnets, more widespread use, better interpretation, more standardized interpretation, the quote-unquote PIRADS system where we look at T2 weighted imaging and diffusion weighted imaging and come up with a score as a very practical way of risk stratifying an MRI. All of that has helped it to really come into the forefront in prostate cancer diagnostics. Much more widespread use now than certainly 10 years ago. The place where MRI is in our guidelines currently is for men who have a previous prostate biopsy. A man with an elevated PSA undergoes a transrectal ultrasound guided prostate biopsy. That biopsy is negative. Now over a period of years, the PSA goes up, there's continuing concern of prostate cancer. So in our guidelines, it now says we should do a multiparametric MRI before repeat biopsy. And what that does is help direct the repeat biopsy to regions that are abnormal, and it improves the performance of repeat biopsy. So that we've known for some time, and it's embedded in the guidelines. What's new, and what we really discussed at today's session here, is if a man has a first elevated PSA and has never had a prostate biopsy, before that original biopsy or initial biopsy, should he have an MRI? Would it improve the performance of the first prostate biopsy? And that's where Professor Emberton talked about that today. And I think the field is kind of moving that direction to probably do MRI before first biopsy for some men. Now we haven't proven that in a well-designed randomized trial. It's not yet embedded in the guidelines, so it's a bit on the leading edge. But clearly Professor Emberton was a strong proponent of that. The critics of that technique would say, you know, you're adding a lot of cost to prostate cancer screening right up front. And many men are going to have a positive biopsy without the aid of MRI. So why are you spending $1,000, sometimes $2,000 right at that first screening episode? So that's the criticism. The other, I think, criticism is that MRI tends to perform very well with experienced radiologists in high volume centers. When you take it out into the community, people are doing MRIs for knees and shoulders and trying to expand that to prostate. The technical performance and the quality of the reads are probably not nearly as good. So the criticisms in a couple domains: cost and reproducibility.